Good afternoon, everyone. Thank you for joining the MAC meeting. We'll get started here in just a few minutes. We're still waiting on quite a few committee members to join, but if you are a committee member, please put your name in the chat. And for the meeting minutes as well, we do have Kim Danzy on the phone, so she has joined us as well. So we'll just get started in a few minutes. Michael, I'll let you know when we have a quorum. We're not quite there yet.
Okay, thanks, Sharon.
Okay, thank you all. Again, if you are a committee member, if you would put your name in the chat. By my count, Michael, we do have a full quorum. So
Okay.
Again, whenever you're ready. Thank you.
Good place to be for July when a lot of people are out of the office. So we're glad we've got enough to take care of our business. So welcome to our July MAC meeting for 2023. And we have a couple of items of business to take care of just at the beginning of the meeting before we get into any of our other agenda items. So we have 2 months worth of meeting minutes. We have the May meeting where we had the public hearing and the June meeting where we voted on the proposed budget items and a few other items of business. So if someone's had a chance to review both of those and would like to make a motion to approve the minutes, we'll entertain that at this point.
I'll make a motion to approve the May and June minutes.
Okay, thank you, Rachel. We have a second?
I will second that.
Okay, thank you. And then we will vote by silence, if you will. So unless you oppose the meeting minutes being adopted, just remain silent. If you have concerns or would like to make some changes, speak now. Okay, thank you. Then we will consider those meeting minutes for both May and June approved. And then the next item we wanted to just talk about is we have a vacant consumer representative position for Medicaid recipients on the MAC. And we've got a couple of nominations, but just wanted to put out one final call. If you'd like to submit someone's name for consideration for the department to include on the MAC in that role. So we probably can wait, Sharon, another week or so before finalizing name submissions, and then I think the department's going to want to proceed, so we'll have someone in place for the August meeting if possible.
Yep, will do. I did receive some nominations, so I will push those forwards so we can have somebody hopefully on by August. Thanks, Michael.
Great. Okay, thank you. So first item on our agenda is the director's report. Jen is out of the office today and unable to join us, so we have a combination of Brian, Eric, and Melissa who will be addressing the topics listed under the director's report. So whoever is first on the upcoming policy changes that will be addressed will let you take that and then proceed accordingly.
Yeah, thank you, Michael. So yeah, Eric and I decided to split this up. Eric, would you like me to start with the policy changes and then take it to you?
Sure, since that's up first, yeah, let's do that.
Yeah, okay, thank you. Actually, Sharon, if you don't mind, I might present real quick. Are individuals able to see my screen?
Yes, you can see it.
Thank you.
Thanks.
Thank you, Brian Roach, Assistant Director, Division of Integrated Healthcare. Speaking about a number of policy updates that are upcoming. The first wanted to speak about is some November changes we are aiming for. First being our long-term acute care prior authorization timeframe. Up until this time, currently until our proposed change in November, the approval timeframe has been 7 days, which we have recognized to be somewhat administratively burdensome. We have reviewed the average stay in a long-term acute care facility, and we are updating our rule to change it from 7 to 28 days. The second policy change is whole genome sequencing and rapid whole genome sequencing for diagnostic purposes. We are proposing to go live with our policy in November, and we have determined that it is largely cost neutral and it improves our diagnostic capabilities. Coming up in January, there are a large number of January updates. The first that came out of the 2023 general session is recreational therapy. This will come with 2 new codes, PICS codes, procedure codes to open. The policy will be added to our rehabilitative mental health and substance use disorder manual, and it will effectively open services for recreational therapists. The Practice Act actually does lay out 3 different recreational therapist classifications. I can go into that if necessary, but we do view this as a positive change as an additional tool to improve the mental health options for recreational therapists beginning in January. Going on, we are developing additional policy around 4 walls. There has been some delay in implementing a 4 walls policy due to the pandemic, to the public health emergency, and we are working towards a policy implementation in January 2024, laying out what restrictions and options there are for tribal federally qualified health centers. Moving on, the next policy item to talk about is 12-month postpartum for women. This would extend the period. Currently, it is 60 days. This would extend the continuous coverage for women who have just entered their postpartum period to 12 months. We have recently gone through a waiver submission to this effect. The bill that came out of the 2023 general session directed the department to submit a waiver with certain restrictions, and we are awaiting CMS response to that. And then the bill does create a fallback plan if that is not approved, to advance with the state plan option, which would go into effect in January. Next, this 12-month continuous for children was mandated from the Consolidated Appropriations Act late last year in 2022. and has an effective date in January of 2024. This will provide a 12-month continuous eligibility period for children. That means regardless of income or household changes, they would be able to retain their eligibility for a full 12 months. And we're working with CMS on just some of the technical details. For example, what program changes may still be available to individuals. Some technical pieces for the implementation, but we will go live in January with that. An additional item is happening in January is the removal of our non-traditional benefit plan. And in other words, everyone that is receiving a non-traditional benefit plan will begin to get a traditional benefit plan in January. This primarily affects the ability to get non-emergency medical transportation, some expanded physical therapy and occupational therapy benefits, and for the non-expansion parents group that are between 19 and 20 years old, they'll get an expanded EPSDT benefit. So that's a positive change beginning in January. And the last item I have as a bullet point here for January updates is our state CHIP program. This was coming out of Senate Bill 217 from the 2023 general session. It will extend a CHIP benefit to individuals who are otherwise eligible except for citizenship. And there are some further requirements that need to be met, and it creates a special fund for this purpose. And in order to stay within the fund, we will operate with an open enrollment period to enroll members as long as we have appropriated funds available to enroll members. And then if we exceed or are bumping up against the appropriation, we would close enrollment. That would go live in January, and we are looking to get additional member information, website details, outreach materials in the next few months. Another item that is upcoming, we are looking to extend the benefit for weight management drugs. This we are looking to see whether it can be accomplished in a cost-neutral fashion. Historically, weight management drugs have been categorized as cosmetic drugs, but recent updates allow state Medicaid agencies to expand this benefit, and we do recognize the clinical utility to expanding this benefit. So we are looking at that as well. We are in the final rounds with CMS of working through the approvals for our medical respite waiver, in vitro fertilization, and oncofertility waivers. We do expect CMS to approve those all in a lump approval, and we are awaiting that very soon. As well, we are about to submit waivers, our 1115 waivers for adult dental, offering dental services to all other individuals that currently don't have a dental benefit. Our family planning waiver to individuals up to 185% of the federal poverty level, and then a chronic disease pilot program that would allow us to contract with a vendor to excuse me, the words are escaping me, to add additional health management options to members in areas that are to members that are not enrolled in an ACO. So with that, that wraps up the policy update. I welcome any questions, or if not, I can kick it over to Eric. Andrew, go ahead, please.
Brian, this is Andrew. Just a quick question, because you mentioned a term and it's the first time I've heard it. So I was wondering if you could explain it a little bit, and that is four walls. What is that?
Yeah, I might actually request Eric's help in explaining the history of this. It is still something that I am learning myself. Eric, are you able
Yeah,
to?
I'm happy to talk about it, Andrew. So basically what the four walls policy is CMS had issued guidance several years ago to tribal facilities that they needed to operate within the bounds of their four walls. And several tribal facilities nationwide had been doing a lot of mobile clinics and services outside of their four walls. And so CMS sent a bulletin to Medicaid directors stating that they were going to start to enforce that four walls policy and require them to operate within the four walls. However, with the onset of the public health emergency, they delayed the enforcement of that four walls policy and kept delaying it during the public health emergency, and finally arrived at 9 months after the end of the public health emergency is the time frame that they will start enforcing that policy. They've offered an option to those facilities that want to continue to operate outside of their four walls to be able to convert to what's called a tribal federally qualified health center. Now, there are a few nuances and differences between the way that a tribal facility can operate as a tribal facility versus the way they would have to operate as a tribal FQHC. And so we're working out the nuances of that policy and making sure that our system has the programming in place to be able to deal with those nuances. Does that answer your question, Andrew?
It explains what it is. I'm still struggling with the why of it, but maybe I'll go and do a little bit more research now. Thanks, Eric.
You bet.
Andrew, if you'd like to connect offline, we actually have someone at Ouch that knows a lot about the four walls policy, so I can connect you to if you would like to learn more, and then I can explain the nuances, obviously, related to the FQHC portion.
Thanks, Rachel. I might take you off on that. Appreciate it. Okay.
Thanks for your question, Andrew. Are there any other policy questions? Eric, the floor is yours.
Okay, great. First off, I'd like to talk about some staffing updates we've had in the division and a little bit of reorganization that we've done recently. So as a lot of you are probably aware, our director of the Office of Eligibility Policy, Jeff Nelson, has left Utah Medicaid. His assistant director, Michelle Smith, is acting as the interim director while the position's being recruited for. Now, Jeff had a dual role within Utah Medicaid. He was both the office director and also the CHIP director. So for the second piece of that, we've appointed Jennifer Weiser to be the CHIP director. She has great knowledge and years of experience working with the CHIP program and with the plans directly. So we're excited and happy that she's been willing to take on that role. And she's on the call if you'd all like to just meet her. Jen, I don't know if you want to say hi quick.
Hi, thank you, Eric. I appreciate that. Yeah, I'm really excited to learn what Jeff was doing as his role as the director, and getting to, I mentioned this in the CHIP Act, but I'm just excited to get to know all of the people that I haven't worked with before in this role. So thank you. Appreciate the introduction.
Great.
Hey,
Thanks, Jen.
congratulations. That's great. This is Brian.
Thanks, Brian.
Okay. In addition to that, Jason Stewart has been made the operations director in Medicaid. But prior to that, Jason had oversight of the Office of Special Projects and Management, and now he will be continuing that oversight, but also have oversight over the Office of Medicaid Operations. We're presently recruiting for a new office director for Special Projects and Management, which was the position Jason had moved out of. We've reorganized a few other of our offices and created an Office of Reimbursement, Coordinated Care, and Audit, and have asked John Curlis to be the office director of this new office. And with that, it left a vacancy in our Office of Financial Services, which we've asked Jamie Sorensen to take on that role, which we're excited about that as well. Finally, we've hired a new Medicaid medical director, Dr. Yoon Kim Butterfield, who'll be starting on July 31st, and our pharmacy teams and medical consultants will be reporting to her. So a lot of changes within the leadership within the division, but we're excited and getting ready to move forward with everything that's happening. So just a quick, I'll touch on the governor's budget items. We have been working on the prioritization of those MAC requests, and then also the department's items, or sorry, the division's items at the department level, and are on schedule to get those submitted to the governor's office in time. So that's just a quick update there. As far as PRISM, our contractor, CNSI, who's been working with us for years on PRISM, recently merged with another company and is now being known as Essentra Health. So if you hear us discussing Essentra Health, you now know who we're referring to. Speaking of which, we've been negotiating with Essentra to accelerate some of the work they're doing on correcting some of the defects in PRISM, and have been able to accelerate the completion of many of them, particularly in the area of managed care. So with that, I'll open it up to any questions on PRISM, prioritization of budget items, or on department organization, or division organization, rather.
So there were a couple of questions in the chat, Eric. I see a question about if you could send out an org chart. Maybe we could just include that in the meeting minutes so people would have that as a point of reference. And then I had a question on, you said CNSI is now Centra or just Centra? How do you
Centra, so it's ACENTRA.
Okay, good to know. And then I had a question you just mentioned about the building blocks. So we had moved up the public hearing from June to May, and then had the vote last month instead of this month, which had been the custom. I'm just curious, timing wise, in terms of what additional flexibility or help that ended up being to the department, getting those building blocks considered and ranked, given just the expedited timeline moving that a month earlier may have some impact on people's availability of getting things ready, anticipating a legislative session. I mean, I know from the department standpoint, there's a certain amount of, okay, you have process to get something in the governor's budget, but if people have ideas about how to improve things or establish a need, trying to anticipate the public generally knowing about a request 9 months before the legislative session starts. I mean, it's 1 month difference. I'm just kind of curious from the standpoint of having it in May versus June and what help that ended up being to the department.
Oh, it's actually quite a bit of help. As you'll remember, a lot of the analysis we do on these budget requests is done by our financial staff. And part of the conflict they have is closing out our books because our fiscal year, as you recall, ends on June 30th. And so it's kind of a running amok there with a lot of work for that group to do in a very short period of time. So having that additional month has definitely helped. It's given them the time to actually write up work on the business cases that will be delivered to the governor's office as part of those budget items. So we do appreciate that expedited timeline.
Okay. Have any information about what's moving forward?
I don't at this point, no.
Well, I know you can't answer, but I thought I'd ask.
Well, it was worth a shot, Michael.
I always try, you know. Okay. Anybody else have any other questions that I missed in the chat? Let's just see. A lot of congratulations. Okay, Dory's highlighted the new acronym, ORCA. That's catchy. We can keep with the in the water.
Gina asked about dental capacity under the waiver. Should it be approved?
Our recommendation is to do it the way that
Like a capacity at the School of Dentistry.
Yeah. So I think School of Dentistry itself doesn't provide all of the care. Just answering as someone who works for the University of Utah, there's a partnership with associated providers throughout the state on their network. And I think they have been doing a lot of preparations to make sure that they have the capacity, but that's one of the things that will be evaluated as the waiver moves forward, is just statewide capacity. So I think good question. I think the general assessment is they're prepared, but there will be an independent review, I think, as part of the waiver review to ensure capacity is there. Okay, and looks like that takes all of the questions. But thank you for pointing that out, Rachel. That was further up than I had scrolled, so we want to get all of those addressed. Okay, so then plan for justice involved members. Is that going to be Melissa or Eric or Brian?
It's
Melissa.
me.
Okay.
Yes. Hi. It's a pleasure to be here. My name is Melissa Aitken, obviously. I am a research consultant reporting directly to Jen Strohecker, and she has me leading the coordination of the Justice Involved Reentry Initiative. So I am just going to present a PowerPoint to introduce this. Okay, just 1 second. I had it all ready to go.
We understand your pain. Google Meets is such an adept technology that most of us are struggling with.
I know.
We understand.
Okay, let's see. There we go. Okay, let me know if you guys are seeing that.
Yes, we can.
Everyone seeing that?
Yep.
Okay, perfect. Yep, thank you. So the intent of this demonstration is to build a bridge to community-based care for justice-involved Utah Medicaid members, offering them services to stabilize their conditions and establishing a re-entry plan for their community-based prior to release. A little bit of background about this population, looking at the healthcare needs. People who are now or have spent time in jails and prisons experience disproportionately higher rates of physical and behavioral health diagnoses. They are at a higher risk for injury and death as a result of trauma, violence, overdose, and suicide than people who have never been incarcerated. Then looking at specifically at Utah, the rate of mental illness in Utah jails is 30% or 6 times higher than the general public. Nearly 49% of justice-involved individuals screened during the statewide risk and needs screening process indicated the need for further assessment for substance use disorder. And then in 2021, there was an audit done, and there were quite a few concerning findings found from that. One that I wanted to point out specifically was that it was found that diabetic patients were not being cared for in line with what the American Diabetic Association recommends. So as you can see, this is a vulnerable population. And then national and state context for Utah's justice-involved Medicaid waiver. So in October of 2018, Congress passed the SUPPORT Act in response to the imperative to implement concrete changes to address the opioid epidemic. This SUPPORT Act required the Department of Health and Human Services to provide guidance to states on how to seek 1115 demonstration authority to waive the inmate exclusion in order to improve care transitions to the community for incarcerated individuals. And then, riding off the back of that in 2020, Utah legislature passed the House Bill 38, the Substance Use and Healthcare Amendments. And this House bill directs the Utah Department of Health and Human Services to seek 1115 waiver approval from CMS to provide Medicaid coverage for qualified justice-involved individuals. So then in June of 2020, we submitted our Medicaid waiver request to CMS, where it still sits today. And then in January of 2023, CMS approved their first justice-involved waiver for California. And at that point, we were told to sort of review theirs and amend ours to align with that, with the chances, with the hopes of the chance that it would be approved if we did that. And then in April 2023, CMS did release a state Medicaid director letter, which then outlined the framework for the justice involved services. And so now this has become the guidance that we are going to be amending our current waiver to align with. So care management flow for Medicaid eligible incarcerated individuals in Utah. This is just sort of a visual to show, and I'll provide more details as we go along, the process that these individuals will go through if this initiative is implemented. So starting on the left, pre-release eligibility determination and application processes. So upon entering a Utah correctional facility, Utah Medicaid actually suspends the Medicaid eligibility instead of terminating it. Upon this, individuals deemed a qualified inmate will have eligibility determined for the appropriate Medicaid program for which they meet eligibility requirements. If an individual was not enrolled in Medicaid when entering the correctional facility, Utah would ensure that during the period of incarceration, the individual receives assistance with completing and submitting a Medicaid application sufficiently prior to their anticipated release date. The next would be the 30-day services provided pre-release, and a big focus has been case management. So case management will be provided, like I said, in the period up to 30 days immediately prior to the expected release date. And it is intended to facilitate reentry planning into the community in order to assess and address physical and behavioral health needs and health-related social needs, support the coordination of services delivered during the pre-release period and upon reentry, ensure smooth linkages to social services and supports, and ensure arrangement of appointments and timely access to appropriate care and pre-release services delivered in the community. The behavioral health linkages. So to achieve continuity of treatment for individuals who receive behavioral health services while incarcerated, the Utah Department of Health and Human Services will require correctional facilities to facilitate referrals to post-release behavioral health providers, as well as share information with the individual's health plan. Enhanced care management. So this is looking at those pre-release services that we will cover. And right now we haven't nailed down exactly what those are going to be, other than ones that we've heard that come down from CMS saying we have to include them. But targeted services will focus on the continuity of care as these individuals transition back into the community. Community supports. So the main goals here are to improve access to services prior to release and improve transitions and continuity of care to the community upon release, as well as improve connections between carceral settings and community services upon release to address physical health, behavioral health, and those health-related social needs. And then lastly, justice reentry and transition providers. So by bridging relationships between community-based providers and injustice-involved populations prior to release, Utah seeks to improve the chances that these individuals receive stable and continuous care in the most appropriate and cost-effective settings. All right, so this slide created just showing not all of the differences between CMS's guidance and our current request, but like the main ones that we're currently looking at. So on the left, we have CMS's new guidance. With eligibility, flexibility is allowed, but we're encouraged to include a broadly defined population. As of right now, eligible individuals have to have a chronic physical or behavioral health condition, mental illness, or opioid use disorder. The coverage timeline they're allowing for us is actually 30 to 90 days, so there is some flexibility there. Our current waiver has asked for 30. Medicaid covered benefits. So these are the three that they're requiring that we cover. And as I mentioned, it's that case management. Also, medication-assisted treatment for those with substance use disorder, along with accompanying counseling, and then a 30-day supply of medications upon release that will most likely be facilitated by the case manager. So our current waiver did not include any of those. So obviously we're looking at amending that portion, as well as we do not have we do not address a reinvestment plan, and we have to have one that will outline how the federal matching funds under the demonstration will be reinvested. Okay, so Justice Involved Reentry Initiative goals. With this 1115 demonstration, Utah will directly test and evaluate its expectation that providing targeted pre-release services to Utah Medicaid individuals will avert the unnecessary use of inpatient hospitals, psychiatric hospitals, nursing homes, emergency departments, and other forms of costly and inefficient care that would otherwise be paid for by Utah Medicaid, as well as improved health outcomes, reduction of strain on our healthcare system, decreased rates of reoffense and relapse, and successful re-entry demonstrated by these individuals becoming positive contributing members of our community. So next steps, we're going to continue our dialogue with CMS, continue to engage stakeholders, because this really is a big project and there's a lot of different people that need to be involved. And then formulate an implementation plan with milestones. We're going to determine if the policymakers support this initiative. If approved, we would submit our initiative request to CMS, and then obviously if they approve it, we would implement. And I believe that is it. So any questions? And I think, Stephanie, go ahead. Stephanie Burdick. Oh, your question is in the chat.
Sorry.
Do you
Yeah,
have?
I was just.
No, go ahead.
Yeah, go ahead. I was just wondering about like the specific community support, and then I also wanted to check in and ask about any additional privacy, like any additional data concerns about like data, all the data sharing that would go in on this, or like are there ways that you're trying to kind of like manage that risk or beyond kind of current practices?
Absolutely. Those are great questions, Stephanie. So as far as the list of specific community supports that are potentially reimbursed, we do have access to all of California's, essentially all of their project plans and exactly what they're doing. They've done a really great job. We haven't currently outlined that. We submitted our waiver, but this was all a lot of news, and we're just in the process of sort of figuring out engaging the right stakeholders and determining which services. So we don't have a list of community supports that are like written out right now, but it's definitely something that we're working on. And like I said, we do have California's information. They actually have a website that's pretty great that maybe we can share in the meeting minutes that are shared after this, so we can go and see exactly what their project looks like. I hope that helped. Did that help, Stephanie?
Yes, and then the data question as well, I guess is my second
That's
question.
right. Yes, data sharing is a huge it's a huge point with this initiative, obviously with the corrections and our side and PRISM, that, Lenny, like I said before, we haven't 100% dived into, but we are obviously, HIPAA and security. Those are all things on our mind that are going to be taken into account. And CMS will also be heavily regulating this and have things that we have to be doing to protect that as well. Okay, Jennifer Marchant?
Yes, thank you. I just wanted to say thank you for this presentation. Oh, can you hear me?
Yes.
Oh, okay. Thank you for this presentation. It is so important.
Yes.
I taught in corrections for 4 years, and I just cannot stress how much this matters. I do have a question, and you may not have the answer right now, but I'll just throw it out there, so we can think about it in the future. In your presentation, you listed that upon release, they have a 30-day supply of medicine. Now, is there another program in place that will help get them long-term medication programs? As in teaching in that 4 years, there was such a high recidivism rate, meaning relapse or reoffending, because they could not get access to decent health care or mental health care beyond that 30-day supply. And then they just wound back up in the system, and it was a vicious cycle. Anyway, I don't expect you to have the answer. It's a really broad question, but just wanted to throw it out there if you had any information on that.
No, I think that's a great question, Jennifer. And one thing that I will say that I know is that there is a lot of focus with that case management. And, that doesn't end as soon as they're out. There is going to be a post-release case manager, whether that's the same one that was in the prison, or we do a warm handoff where that care plan that's tailored to that individual is then given to them. And then from there, they are there to ensure that, it's a successful transition to the community with appointments. I know you mentioned specifically with the medications, hopefully making sure that they're going and getting their medication. They're getting to the appointments where they have to get the prescription for the medication. So it's definitely not a you're released and then we're done. That's the one of the focuses of that case management. So, and I agree, this is a really exciting initiative, and it's a very vulnerable population where we could do a lot of work.
It is. I cannot thank you enough.
Sheila.
Hi, Melissa. Thanks for the
Hi.
presentation. I had a question. So, and I think it just depends on how they come into the system. Like if they're with an ACO, they come into the system, they come back out, and then they're back to the ACO. I'm just wondering, what does the case management handoff look like? Because I think that's going to be really key to make sure that these individuals don't have to kind of go through the whole process all over again. Their whole, you guys will already, the case management team working with them in the system will actually have so much information and realizing the sensitivity and the requirements for consent and things like that to share. But just wondering what that handoff will look like, because I think that'll be really key.
Yes, I agree, Sheila. So right now, that is something that we've been thinking about. And, I think that California, or I know that California has done fee for service in the prisons, and then they've done a handoff to the ACOs, to their managed care plans. I think that, we haven't made a solid decision yet, but we would like it to be the same case manager, is from my understanding. So that way, it removes a lot of those barriers and hurdles to jump over as far as like sharing that information and that handoff. Does that help?
Yeah, thanks. It'll be fun to kind of watch this all unfold and how that all shakes out.
Yeah, it is a lot of work, but really exciting. Andrew?
Yeah. Thanks, Melissa, for this. I really appreciate it. Two related questions. What are you thinking about in terms of a process for gathering stakeholder input, and what is your timeline looking like for doing that?
Yes, exactly. I knew I was going to get the timeline questions. Thanks, Andrew. Right now, as I mentioned in my presentation, we have our waiver submitted. We did that sort of not blindly, but we didn't have all the guidance that we have now from CMS. And now that this guidance has come out, we're really, and after we've begun speaking with California and sort of getting an idea of what their project was like, with the understanding that theirs was way more massive than ours, obviously, with it being the state of California. But the reason why I'm saying that is because I feel like this is a bigger, a project than, maybe what we initially had thought. So I definitely think the timeline has extended. And I actually don't have a solid timeline for you. Oh, go ahead, Nate.
Sure. Yeah, thanks, Andrew. It's a great question. And as Melissa stated, we've already have done the public comment and submission on the original waiver request, and that's in front of CMS. And we hope they'll act on that one and let us start moving forward. But as Melissa said, there's a much bigger opportunity that CMS has now opened up for us. Bigger opportunity also means that's going to require more funds. So that is something that's going to have to take into account the legislative process too. So we're going through discussions about whether or not how this fits into the potential of fitting into our governor's budget request. That will play itself out. We'll know by December how that works out. We'll have the legislative process that will weigh in and decide whether or not this is funded. So at that point, if we have a funded request, that we would go through the normal 1115 process and have the public comment on that development. So it's likely something that would develop next year if funded by the legislature.
So Nate, just to make sure I'm understanding correctly, the thinking now is that if CMS approves the original waiver, great. If not, moving forward with a with some sort of a request, funding request to the legislature, and the bulk of the policy related to that request to be developed, depending on whether the funding is appropriated and the amount of the funding. Is that what I'm hearing?
Yeah, for the most part, one of the parts as you talked about, sort of that connection. So if we were to get the original request approved, sorry, let me get that spit out. If we were to get the original request approved, we may still, and there's some significant advantages to go to the now state Medicaid director information.
Yeah.
So we may do both. I guess I just don't want to preclude saying we may get approval and we may move immediately into, hey, can we go for something bigger?
Okay. Thank you for that. I appreciate it.
Thank you, Nate. Looks like Stephanie has a question for you in the chat, Nate.
So Stephanie, to your question, let me just read that so everyone, they're not looking at it. Do you have funding for a focus group with consumers, people with lived experience, or do you have to wait for legislative approval for that? That's something we could probably take a look at internally as we're building, sort of developing this concept, because it is a little bit, in these discussions, it is a bit of a chicken and egg type thing, like how much does the department do in preparation for these types of requests? And how much do we need to wait until the legislature is weighed in? And that's something we could assess about whether or not that would be something that if we would want to wait until the legislature funded it and we just know that this is something that's moving forward, or if that's something the department would want to tackle ahead of time, and do it as part of the development of the information that might be presented to the legislature next year. So that's we'll look into that. That's a good question.
Thank you so much for your input, Nate. Are there any other questions?
Melissa, I have one more related question for Nate, if that's okay.
Absolutely. Take some of the pressure off me, Andrew. Thank you.
Oh, my pleasure. Nate, I don't know if you are in a position to be able to, but given that there doesn't sound like there is a concrete proposal yet, but that you are planning to come to the legislature with a request for something. How are you talking to what are you talking to legislators about now, and how are you talking to them about it?
Yeah, great question. So one thing that we are talking about for sure, we have the approved and funded waiver request, the existing one. So we're definitely talking to them about what's on the table right now with CMS and what we might be able to get approved sooner rather than later. We're definitely talking to them, and Jen's presented on this in several different formats, several different times, about what CMS has now authorized through the California approval, the new state Medicaid director. So sort of setting that table of here's the opportunities that are out there. The part that we don't know about, and this is just, we've made several references to the budget process through this discussion. We don't know until the governor's budget comes out about whether or not this would be something that the governor would be approving to go into the budget and supporting to go forward. So at that point, we'll really have a better idea about whether or not that's something that the department will be able to push during the legislative session. So that you had several questions. I'm not sure if I checked all the boxes. Was there anything I missed?
No, I think you covered it as well as you're probably able to at this point. I was just gonna ask and totally understand if you can't provide too much detail, but what did you ask the governor to consider putting in his budget around this?
That you are right. That is a question I cannot answer. And actually, we haven't submitted. I mean, in full disclosure, the GOPB process this year has the department submitting its request in mid-September. So we received guidance from the governor's office about what the budget requests need to look like, the format for them, and those things. We're going through that process internally, reviewing, as was mentioned earlier, the MAC prioritizations, the requests coming from the different operating units within the department. And then we'll start meeting with GOPB and have our formal submissions to them in mid-September.
Right. Thank you. Appreciate it.
Sure.
All right. Were there any other questions? Jennifer Marchant? Yes, go ahead.
Just want to say again, please keep up the good work. This really does change lives for the better. So just thought I'd throw that out again. Thank you.
Thank you so much. And it's a pleasure to be here this afternoon. You guys were a great audience, and this is an exciting, possibility. So I appreciate it.
And I guess just building on both Andrew and Jennifer's comments, when I keep saying what the department can do and will do, that doesn't limit what all of your ability to do. And, Andrew saying what discussions have been had with legislators, what thoughts have been going forward. The information is out there. It's public information related to the state Medicaid director. The analysis that Melissa has just done and shared with you is out there about comparing where Utah's current waiver request is with the state Medicaid director letter. Through the process, you are all able and capable of raising those questions too with your elected officials if you have an interest in this concept.
I do see Bill in the chat is asking about the materials for California. And Bill, those are going to be sent out in the meeting minutes. So you don't have those yet. So you're correct. They are not in the materials that were sent out prior to the meeting.
Okay. All right. Thank you, Melissa, and everyone for a good discussion on that topic. Let me just ask back to Eric and Brian, do you have anything else you were planning to present? We have PRISM update listed. I know we talked about the change in vendor, but anything else there you wanted to hit before we move on to the next agenda item?
No, just to reiterate that we had accelerated our timetable on a lot of those defects and change requests that we have outstanding with Essentra. We've been working with them to try to increase the number of hours that they can spend working on those types of items. So hopefully things will get corrected at a more accelerated rate from point forward.
Okay. Thank you. Then let's move on to item number 3, unwinding continuous Medicaid eligibility update from Michelle Smith.
Thanks, Michael. Hi, everybody. My name is Michelle Smith, and I am the interim office director for the Office of Eligibility Policy. I think you guys are used to Jeff giving this presentation. That's a very tough act to follow, but I will do my best. Just to let you all know, we are entering month 5. Actually, we are in month 5 of our unwinding efforts for the state of Utah. We started in March. We did submit our monthly report on our unwinding efforts to CMS on July 8th. I think Jeff has shown you all and mentioned in the past in this meeting that we do have an unwinding webpage where you can find all of those reports that we submit to CMS, as well as any other information about Utah's efforts around unwinding, and that's at utah.gov, or sorry, excuse me, medicaid.utah.gov/unwinding. Okay, so with that said, I'm gonna go ahead and present a few items. So this first item, I'll wait for this to show up. This was in the materials that Sharon had sent out earlier in the unwinding summary. This is just a snapshot of our total enrollment numbers, as well as individuals that are still being held open during this unwinding period. So you can see for the month of June, we have a total enrollment of 470,945 individuals, and there are 206,520 individuals that we are keeping held open during this time. You can also see, obviously, over the past 3 months, just the downward trend, just as a result of our unwinding efforts. So I'll move on and share our unwinding data dashboard, which is also available on our unwinding webpage. This first tab that I'm going to show you all is the review outcomes. This is a snapshot of the report that we submit to CMS. So this is the June numbers from our July 8th report that we submitted to CMS. So you can see roughly around 24% of the individuals in that report we were able to unsuccessfully renewed through the ex parte process. If you're not familiar with ex parte, that is basically when the agency is able to complete a renewal without any participation from the Medicaid or CHIP member. So again, around 24% of those. We also renewed around 15% of our members through the pre-populated renewal notice, either online through My Case, which is the member portal at Department of Workforce Services, or they provided that paper review form to Department of Workforce Services. We closed and determined ineligible, meaning someone was determined to be over income, over assets, for an actual valid reason, roughly around 2%. And then around 54% of those individuals for that month of June, we closed for procedural reasons. These are individuals who, did not complete a review form or provide the verifications that were requested from Department of Workforce Services. And then close to about 5% of those individuals still, yes, Stephanie.
Sorry to interrupt. In that part, it doesn't seem to differentiate between who's not filling out a renewal form at all versus who is not filling out verification. Do you have that information?
Yeah, that's a great question, Stephanie, and it actually leads into the presentation that I'm going to give next. It's actually listed next on the agenda to talk through procedural terminations. So I can talk about that a little bit more there, but basically I'll give kind of a, it's okay to jump ahead, Stephanie. That was a great question. But I can state that here. We are actually in the process of doing a deep dive into that data right now with Department of Workforce Services to look at those reasons more closely. So great question. So I'll kind of pause here with this snapshot and just ask if there's any further questions on what I just presented. Okay, so I'm going to go ahead and proceed. Obviously, the next tab, it shows our movement for our Medicaid members to CHIP. You can see unwinding efforts are occurring. We are seeing an uptick in our CHIP enrollment, children moving from Medicaid to CHIP at their renewal. I think this tab is a really important tab to highlight as well. This shows all the great work that DWS is doing right now. They have a lot of work that they're facing right now. And we just wanted to showcase that with this tab, just all of the applications that are coming in, average days to decision for those applications, where those applications are in terms of status, pending, approved, or denied, and then other reviews that are happening for their other programs such as SNAP, TANF, and childcare. This next tab is our presumptive eligibility. This is one I know Jeff mentioned in the past. This is kind of one of our things we felt was kind of one of our canaries in the mine, where if we saw an uptick in here, we would know that there's that potential that there might be individuals who are being closed that may come back to us. And then this last tab is just everything around, call volume, average wait times for the month of June, as well as the call abandonment rate. And as you can see, we saw a slight drop from the month of May to June in each of these categories. So I will stop here for the unwinding portion of this and just ask if there are questions. Stephanie, yeah.
Whenever somebody does just like stop waiting, how does that change the wait time? Like, does it, like, what is the, I guess, like the math equation, like to make, like, how are we determining the average wait time? I guess, like, this call abandonment, like if I call and it's like, I just hang up because I'm in the middle of something, right? Or I know people who they're doing it on their lunch break and they've talked about how they can't wait because they're getting, I see that the wait times are saying that average, but I talked to members who said it was over an hour. Like they just couldn't keep waiting. They had to go back to work. And so like, how is that impacting the average? Like, is that looking like somebody answered their call or is it like not factored into the average wait time? I guess, does that question make sense?
No, it does. And thanks for that question, Stephanie. And I believe we have, I'm actually going to pass that question off to Dell OMB. Thank you, Dell.
Stephanie. So the call volume and the call wait time starts after the interactive voice response or IVR menus and an individual selects an option to move into the queue. Once they hear the call wait times, they are given if they're predicted to be over 45 minutes, they are given an option for a callback. But if they choose not to do a callback and they hang up, then that takes them out of the equation of the wait times, but it keeps them in the call volume and the abandonment rate.
Thanks, Dale. So is a lot of people are, so basically like the average, it's like the average wait time for the people who like get all the way to a person. So like if 15 people today wait 20 minutes and then they just give up, that's not really reflected, I guess, in the average wait time.
It just depends on, so our system is set to look at the previous 30 minutes and estimate the call wait times based on volume. And so at the beginning, when they're given their estimated call wait time, if it's over 45 minutes, they will be offered a callback option where they enter their phone number and we will call them back. If they choose not to enter the callback option and just hang up, then that's going to be figured into all three of them. But average wait times, that will remove them from the queue and then recalculate the average wait times based on the volume waiting. I know it's complicated. Did I explain that okay?
You have that in like writing. If you have that in writing, could that be sent out to the members, or I can just email you, Dale, or if nobody else can?
Yeah.
I guess I'm trying to understand like members that are saying this. I'm just trying to like make this make sense and what I'm hearing, like just like from people.
Sure.
It just seems like there's really high wait times right now, and so I just want to.
Right. I just put my email address in the chat, Stephanie. If you'll just email me and ask me for that, just a reminder, like a 1-sentence reminder, then I can get you something and we can get it to Dory to send out to the group.
Okay,
what we struggle with call wait times is we're basically dealing with 150% of our normal workload because we have our regular reviews, plus we have an additional 50% of additional reviews that we've been keeping open. And so we have to kind of walk a tightrope to decide how many people we have on the phone versus how many people we have processing. Because if we put more people on the phone, then cases aren't being processed, which causes more phone calls, which causes longer wait times. We do have a self-service option on our phone system, as well as abilities for customers to log into My Case to check the status of their case. And we do advertise that as basically 0 wait time. What I don't like to see is that our customers are waiting so long just to get an answer is we've received it, we'll work it within 7 days. And so we do encourage our customers to use the self-service IVR as well as My Case to just check the status of their case so that they don't have to wait on hold for so long. I did see another question on the average callback time. I don't have that right off the top of my head, but I believe it's that they remain in the queue. So whatever the call wait time is when they request a call back, that call still remains in the queue. And then when their time comes up that they would normally be answered by a customer, then they receive a call back.
So thank you for that explanation. So there are some, so I hear you about like having people use My Case, having people use that initial, I don't know what that is, but self-service, whatever. I guess like there are some things that like you actually can't do on My Case, and they wouldn't, like, you can't request an extension on My Case, right? You can't, as far, if I understand correctly, like there's things that like would be, it would make sense for those to be easy. And then there's information on My Case that is not consistent. So you can have a form notice that doesn't match other information on My Case related to the renewal. And I feel like these inconsistencies are what would drive somebody to want to make a phone call. And that isn't because, like, that's because the system and like ERAPs, there's like problems in the system that are causing people to not, that are trying to get through this process. And it's just, it's like, it doesn't make sense the way that some stuff is being phrased, like 30 days from the time that we send out this notice, but then like another place can say that your renewal is this time, like, and they don't match. And I just think that like when there are examples like that, and when there are things like requests for extensions and like other information that like, you know, I don't know a lot of people that actually want to be on the phone with like eligibility workers all day, right? But like they don't have opportunities to get that information elsewhere. And it's really just an inaccessible process. And I'm not trying to beat you up on this, Dale. I know that you're doing the best you can, but like, it's just, it's frustrating because at the same time, like a lot of Medicaid members are working and like, this is like, and they don't have paid leave and they are navigating complicated medical situations. And so like, this is a lot of their time because it's like the time tax is just way too high and people are dropping off because they are not, like the system is not set up to enroll every eligible person in an easy way. And so I guess I'm just trying to understand, like I hear all of this and I hear that it's like a lot for your team, and also like respectfully, like we've just like known this was coming for a long time. So anyway, it is a little bit frustrating because I don't even know what to tell people. And I feel like I'm a very informed Medicaid beneficiary and I'm getting asked questions that are so complicated and I have no idea how to help people even find the answer. It's just really hard. And it's just a lot. It's a lot of like, I don't know. It's just a lot. So I think, anyways, I'm sure Michelle, you're going to continue about this, but
No, I agree, Stephanie.
that's a lot of people dropping off because they're not able to get through like a complex process. And that like breaks my heart, you know? So I just think we've got to like figure out how to make more people get through the process, and the system has to work better.
And we are in the process of developing a report to show how many people who receive a closure actually contact us and regain eligibility or re-enroll. And preliminary results is that it's a pretty good number. And so even though it's administratively burdensome to both the customer and to us, we do see that people are regaining eligibility. we're just in a really funky time right now with the public health emergency ending. I mean, our staff are, I mean, I don't want to like create a sob story, but our staff are burned out. We're approving overtime, and it's the summer and they're not able to take vacations, and we really are trying to do the best that we can.
I appreciate that, Dale. I sure you understand my role on this committee is to speak for the people who like they're not going on vacation. You know what I mean? Like they're just
Right.
like my neighbor, just like she's making $10 an hour. Like it's just like life is hard for some of these folks. And so I hear you, and I care about that, and I want you guys to serve your workers in a way that doesn't burn them out. But like this is also like in my this is like what business would seem think that this is like acceptable? Like no business would operate like with these metrics, and I just struggle to know how to get this point across whenever we're at this point. And I hear you, and I'm not. It's just.
No, I agree, and I think Michelle's going to cover some things that we're working on that hopefully will reduce some of that burden for both our customers and my staff.
Yes, I'm glad you said that, Del. That's absolutely right. And I think once I move on to address some of those, strategies that we've talked about to address those procedural terminations, I think that might help. But I just want to ask one more time, are there any other questions about unwinding? Okay. All right, well, I will go ahead and I will switch gears over here to what we've been talking about a couple of times. I was asked to go through CMS released last month some flexibilities for states to consider around procedural, looking at ways to improve their procedural termination. So we've put together, a plan that we feel is really good in hopes of accomplishing a few things, accomplishing what Del just mentioned, where, we have, a high level of work that is in front of us right now, and eligibility workers trying to figure out ways to be more efficient and accurate in the work that we do. So I will just go ahead and get started going through this. So I want to start off just giving a brief introduction of what a procedural termination is. I'm not sure everybody is aware of what that is. So a procedural termination is basically a disenrollment for procedural reasons or administrative churn that occurs when the state is missing information, which can include forms or documents to verify their eligibility. Currently, our procedural termination rate is at 97%, which obviously seems very high, but this is when we measure that with the total of disenrollment. So the denominator does matter when you are talking about that procedural termination rate. So I do want to add here that is with total disenrollment. If we change that denominator, like I showed you earlier, for the month of June in our CMS report, and if you use that for all reviews in the month of June, and out of closures there, it is 54% is our total disenrollment rate. And yes, Michael, please.
Thank you for that information, because as I was looking at that report in preparation for this meeting, I was thinking, okay, yes, 97% seems very high, especially given a report that Becker's Healthcare has issued yesterday. I guess CMS had a press release where they indicated, and they didn't name the states, that a half dozen states they have told to stop doing their reauthorization or review process for redeterminations because their metrics were so poor. And one of the things the article talked about was a few states, New Mexico, Georgia, and South Carolina, had this procedural termination rate above 90% as being a metric of concern. So I just thought I would ask if we have been put on notice as a state that we are to halt our redeterminations because our rate is so high, like some of these other states.
Yeah, no, thanks for bringing that up, Michael. And I'm not sure, Brian,
Sure.
if you're
Yeah.
available, if you want to address that.
Yeah, I can jump in. So, I mean, first off, Utah is not one of the states. And I would also clarify, having read that article, they don't necessarily say that those states you mentioned are the states that are the ones CMS asked
Agreed.
to pause procedural determinations. I think
No,
there
they're
was
just
a bit
stating
speculation.
Problems. Yes.
Yeah, there's a bit of speculation about who is being asked to pause activities and what might be motivation. But we do still consider ourselves to be in good standing with CMS. We have not been asked to pause disenrollments, and we have been fully responsive to all CMS requests for retaining in that good standing. So I just want to reiterate something Michelle said. Both rates are accurate, whether it's 97% when measured as a total of disenrollments or 54% when measured among all reviews. Neither is better or worse than the other. They're just different ways of looking at the procedural terminations.
Yeah, but it, I guess, maybe does kind of speak to some of the procedural problems and some of the situations that I think Stephanie's trying to give voice to. So when we have the end of April reviews done for who stays on in May, the department reported that 35,000 individuals were terminated. And then the very next month, or within a few weeks, you added 7,000 of those people right back onto the rolls, so that it was 28,000. So that doesn't seem to me like you have people reapplying, navigating the phones, and submitting a new application within a 2-week period and having it be redetermined. So I think we have to recognize there are some problems going on in the system. We may not be in a position where there's a cease and desist order by CMS at this point, but I think the role of the committee is to push, ask some questions, and I think that's kind of what we're queuing up here. And I think as we talk through these strategies, I would like the department to speak specifically to how that each one of those strategies will address some of the problems that members who have had their redeterminations done over the past 3 months would be having a different experience for those who are having their cases come up after these strategies get implemented. So thank you for taking the question, and we'll let you continue.
One last landscape I'd add, just for context, to reiterate, is we did plan our unwinding strategy such that individuals who have used their Medicaid benefit the least or less recently, or individuals that we knew to be ineligible for Medicaid were put at the front of the line for renewals. It is an important context that we do not expect the closure rates to be the same throughout the 12 months unwinding. We did deliberately put individuals most likely to close at the start of the line. So
understood. And I guess if you're going to cite that plan, which is fairly well known, how has your forecast of member months, how does that stand up to actual enrollment for those months?
I don't know that we've gotten to that specific of a forecast to be able to compare that.
Okay. Yeah, I guess
at least
it's acknowledged that you were front loading the most likely to disenroll. And I'm just curious if, as you projected those most likely to be disenrolled in the review process and started working through those cases, how you're looking at your numbers to say, are we doing better or worse on our disenrollments? Are we disenrolling more people than we had anticipated? Because you definitely have member month projections for all of your budgetary and enrollment scenarios. So I'm just kind of curious if that has been a baseline metric in terms of estimating where you would be at. And if you haven't done that, that's fine. I was just curious if you have other metrics that would give the public a sense of how we're doing, rather than just a sense of, we anticipated that we would have higher percentage disenrollment in the first few months. And since we're going through those, not really having anything concrete to benchmark against to know, are we doing where we expected to be, or is there cause for concern? So that's what I think I'm looking for in terms of transparency. And are we on plan, or are we in worse shape than where we thought we would be?
Right. And broadly, we don't have a benchmark or an indicator of expected disenrollments, but we are presenting this plan to address what we think is a high procedural termination rate, and doing some process improvements accordingly. So Michelle, you can go ahead.
Okay. Yeah, no, great. And great questions. So as you know, Brian and others have mentioned, here we put together kind of, you know, our plan on, you know, strategies and steps that Utah is going to take to address the procedural termination rate that we are currently facing, recognizing that, you know, we do need to address that and look at ways to improve that rate through streamlining application and renewal processes, ensuring clear communication with our members. I believe there was a message in the chat around multiple notices going out and confusion around that, and we recognize that, and is one of our strategies. Providing adequate support for documentation and submission, and implementing timely appeals processes to rectify error and prevent unjust termination. So just going to briefly, before we go into the CMS flexibilities, just talk about what we currently have in place and what we're planning to build upon to help with that procedural termination rate. So this first strategy, we are actually in the process of automating our ex parte process. Again, like I explained, ex parte is when you complete a renewal without member participation. Today, this is a manual process for eligibility workers. I think you heard from Dell that, you know, workers are faced with a large workload right now. So we're trying to look at ways to be more efficient, number one, but also, Michael, to your question, you know, how does this tie into, you know, helping with that, you know, procedural termination rate? We believe that by automating ex parte, we will be able to take that work, you know, off of an eligibility worker's, you know, desk, if you will, and have them actually focus on those cases that are unable or unsuccessful through the ex parte process and require that additional review and looking at. So we actually are going to implement our first phase. We're doing 3 phases of this, and we're implementing our first phase next month, and it will be effective for September reviews. So we're hoping to see an increase in ex parte, and by doing that, again, we'll be able to not only be more efficient and take that work you know, off of a worker's hands, but also, you know, keeping members eligible who are eligible, right? Sometimes that falls through the cracks through a manual process. So we're hoping that by automating this, the system can identify those proper individuals who are still eligible and simply update their renewal for the following year.
Yeah, and I guess one question would just be, given that the state has 12 months to review all of these cases, why are we reviewing so many that DWS employees are having to do overtime rather than try to figure out how to do it on a meaningful workload basis and give due diligence to all of the cases that need to be reviewed. It seems like whatever the scheduling process is overly onerous in terms of a workload standpoint. And if you're putting too much pressure on the employees to review the cases and getting X number of cases reviewed within a month, to stay on schedule, if you will, not that we're going to exceed the 12 months. It seems like we're being overly aggressive on getting them all done in a 8 to 9 month period of time. Any thoughts as to appropriate workload balance over the 12-month period of time? So someone enrolled in Medicaid feels like he or she's getting a fair chance to be reviewed with a reasonable workload expectation of the people processing the case.
Yeah, I think that's a great question, Michael. And before, I know probably Brian and Dell want to chime in on that, but I will add that, and you might have read some of the materials that CMS put out prior to unwinding efforts. I think every state was faced with staffing concerns, right? This was a lot of work, for states to try to accomplish over that 12-month period. And I think in an integrated state as well, recognizing, Medicaid and CHIP are not the only programs that, the DWS has in front of them, right? And there was not any sort of, during the PHE to keep SNAP or, TANF or do any sort of unwinding effort. So there wasn't the ability to spread those cases over that 12-month period. So Brian actually helped with our renewal distribution effort. And I know we've talked about that here as well. That's also on our unwinding page where it does show, you can pull up and look at how we tried to do what you're stating and distributing that work evenly over that 12-month period and not necessarily bombard any team at DWS. And for some of you who are familiar with DWS, they have hierarchy teams. They have an ABD team, a CHIP team, various teams based on specialties. And so I think Brian was looking at that as he was doing that renewal distribution to try to spread that effort across so that, one area wasn't being bombarded. And again, I just kind of wanted to add that, but I'm sure Brian and Dell, you probably want to add to that.
Yeah, I think one clarification as well is that cases were we distributed based on case counts, and as I think many people know, some cases may have one individual, some cases may have 10 individuals, and there's some natural variation. And it just so happens, even so, going through the effort of distributing cases evenly over 12 months, some months have more individuals just by natural variation of individuals per case. So that can explain some of what feels like higher numbers. We just saw by happenstance the first 2 months have higher numbers of individuals based on count of individuals per case. I'd also welcome Dale if you want to speak to the other questions.
Sure. I would just say that when you look at the graph that Michelle showed, you can see that Medicaid enrollment, I think, increased more than 100% easily. And so you've had customers that either didn't know they had Medicaid. Obviously, they didn't use their Medicaid. A great number of them. The Department of Health and Human Services sent out a notice to all recipients in February. We had tons of calls saying, I didn't even know I was on Medicaid. I have insurance, close my case. But what you see now is that it's increased by almost 100% with people that have never, in the last 2 to 3 years, they've never had to do a review. So they receive a review in the mail and they're like, well, I don't need to complete this. I still have it. And then they get a closure notice 10 days before the closure date. and they panic. And so I think the burnout of our staff is more psychological than anything. They've seen their caseloads per employee grow to over 800 cases per employee. When I started 31 years ago, I had 120 cases and I thought I was overworked. So I think of a lot of it as psychological, but I think now our enrollees are kind of in a panic because they realize that this time it's for real, and they may ignore the first review that goes out 6 weeks before the closure. But when they get that actual 10-day closure, then we see kind of obviously an increase in calls and then an increase in panicking.
Okay. Yeah, and I am obviously somewhat familiar with how this program operates. I think you'll grant me that.
Yes.
But just recognizing if you're terminating people and then they're reapplying, that's a cyclical process that presumably we could avoid with some type of planning around how best to reach out to the people. So recognizing we are where we are, and we'll look at these proposed interventions or whatever to see what we can do. I think as we look back on this in 6 to 8 months, I want everyone to be on notice that I'm going to be asking for a report to be presented in the MAC coming up about how many people were terminated and reapplied for the program within a 3-month period of time. So we will have concrete measures on the churn impact and the additional work based on people who really were eligible, who were terminated, and then were back on the program within a 3 to 6 month period, to kind of give some visibility to the impact on the people who are trying to be enrolled in the program and stay on services. We fully recognize that the eligibility processes for the last 3 years being suspended has had an impact, and there are a lot of people on the program who are no longer eligible. But for those people who are trying to know the system and remain eligible, like some that Stephanie was speaking to, who are having to wait on the phone for over an hour and are probably feeling a certain sense of desperation to try and preserve their eligibility. Those are the people I think we're most interested in making sure have an experience where they don't feel additional distress and emotional anxiety as they're trying to retain their benefits. So, Michelle, let's go back to your presentation. Thank you.
Yeah, no, thanks for that, Michael. And I don't want to be dismissive. Stephanie, did you want to ask something or add to that?
Well, yes, sorry. I did just want to say that, like, I think I was not the only one to raise the point that, like, a lot of people that got in through Medicaid expansion have never done a renewal before. And so, like, to Dale's point, sure, there's people who, like, have been enrolled for a long time and, you know, they haven't had to. And also, like, they got enrolled during COVID and with expansion, and they don't know how to do this process. And that is not new information to any of us and to any of the state. That is something that was known for a long time. And, you know, if you have the numbers, I would be interested to know how much Medicaid dollars have gone over to pay DWS for the eligibility workers this year compared to, like, let's say 2016 or 2017 before. Like, I mean, like, I guess I just see it as, like, taxpayers funded Medicaid expansion, knowing that it was going to, like, increase the amount of people on Medicaid. And, you know, through the COVID, we, like, got more people on Medicaid, but also, like, keeping them on Medicaid at this point is, like, really important to keep integrity to the ballot initiative that voters passed, and that I think that, like, they chose to raise their taxes for. And so it's like y'all have to hire more workers. I don't know, like, some of these things, like, I hear all of this, and also, like, you know, hospitality has seasonal changes and they have to hire more during the, like, on season than they do the off season. Like, this is, like, not new information. And so I do feel frustrated because, like, to a point that Michael was perhaps making, but one that I can speak to personally, but also that I pick up on a lot from like a lot of outreach that I try to do to try to help y'all, by the way, just because I care about my neighbors and my friends and just random people that I don't even know. Like, I will say that like the trust in government in this population group is not great. And a part of that is because it's so many interactions. It is not positive, unfortunately. And I'm not blaming anybody. I know that y'all care, but it is a problem and it is going to impact how these people show up and keep showing up. And I know people who are like, it's just not worth it anymore. And that is a failure. Like, that is such a failure for a person that's trying to pull themselves up to give up because they don't feel like it's worth their time. They were mistreated by a staff member who might be burnt out, but who said something like, that racially profiled them, ask them if they make tamales and that they get paid under the table, if they get treated differently based off of some particular part of their identity or whatever reason. I just think that like these stories are hard to like, it's just like, I can have compassion and grace for like the workers because I know they're doing their best and they're not like billionaires, but like, I also feel very frustrated that there was not like, that there was not more done. And if I'm being completely honest, it does sometimes seem like agencies aren't on the same page, and that one agency seems a little bit more invested in making sure that every single eligible person gets enrolled than another agency. And it's really frustrating because none of this is new, and it's hard because anyway, I'm sorry, Michelle, to like derail this, but this is just like really, it is it's hard to not, I don't feel like there's actually, I don't even know if I don't know what DWS's philosophy is about whether or not we should be enrolling every single eligible person, because it doesn't always sound like there's consistent information. And I don't know how to interpret things that get said by various people, whether in front of a legislative committee or whether in this meeting or whether in like other conversations. And I just have to like articulate that because again, like, I don't know. It's hard to represent consumers without articulating how often this is one of the number one concerns brought up over and over and over again. And it was brought up in community events and roundtables that I've been a part of. Like, it just keeps being surfaced, and it's not, I don't know what has to be done so that it's like fully heard and that there's accountability for like what members and potential members are saying about their experiences, and about respecting all of the trade-offs that y'all have to deal with in the agencies. But like, it feels like there are failures that are not being like treated like they are actual, like that something needs to be drastically changed because it's not sufficient. And anyway, I apologize for being I hope none of this was disrespectful, but it's just like y'all are in hard positions. I frankly feel like I'm put in a hard position to know how to articulate this feedback to y'all because it is the number one thing that I hear. And I promise it impacts people's trust, which has been said that it's a goal of the agency and Medicaid. Like, it's really going to impact the trust that these people have in government. And we have to like find a way to do, like, there's got to be like much more drastic change than I feel like is really happening.
Thank you, Stephanie. Okay, Michelle, let's have you go back to your presentation. I think we're going to try and hear what the department is proposing. I know in the last meeting there was a discussion about the MAC possibly having a vote on making some recommendations, and we will plan to have that in our next month's meeting. I wasn't sure if we were going to feel like doing that, but after the discussion today, I think we'd like to hear your recommendations, and we will plan to put on the August meeting a vote of the MAC in terms of some proposed corrective actions for the state Medicaid infrastructure that we would like to see done. And I'll work with the members of the committee offline and in preparation for the Medicaid Executive Committee in early August to propose some action for the MAC to formally vote and recommend the department take some additional actions with DWS to get this under control.
No, I appreciate your guys' thoughts and comments and feedback on this. So I want to start off by saying that. I do also want to assure you that our agency, DHHS, has worked very closely with DWS in putting together this plan, and we are both really committed to seeing this plan through. So I just want to assure everybody of that. We do recognize that we do need to address these procedural terminations. So I will continue with the plan. So obviously I discussed the first strategy. Our second strategy is around data. There were some questions around this. I believe, Stephanie, you had this while I was reviewing the unwinding update. We are actually in the process of going through the data, doing a deep dive into those procedural terminations to try to figure out, what we find and potentially some additional strategies that we might gain an insight into what we find. Another strategy that we've discussed with Department of Workforce Services is putting out a text message reminder. Currently, if you have a MyCase account and you've signed up to receive electronic notices, you actually get a text message reminder. And again, Dell or Maritza, correct me if I'm wrong on that, but you do get a text message reminder to go into MyCase and complete your review today. That's correct, right?
You can opt into text, email, or both.
Okay, perfect. Thank you for clarifying. And so one thing with that, we recognize not everyone has a MyCase account or wants to get a MyCase account or opts into that. So we're looking at how to incorporate that text message reminder to all of our members so that when there is that potential that you are unsuccessful, we are unsuccessful of completing your renewal through ex parte, and that pre-populated renewal form goes out, we want to also send a text message reminder to that member to just let them know, hey, we sent you a review form, please complete that, right? Just any way that we can kind of alert, individuals to, what is needed from them. I was fortunate, as well as my counterpart at DWS, Maritza Erickson, who attended an NAMD unwinding conference last week. And we got a lot of really good, I think, feedback and strategies from other states, as well as listening to a member panel, which was extremely powerful and I think helpful as, we were talking through some of these strategies and I think show what we're trying to do here. And this text message was one of those strategies that was discussed. Just making it clear to individuals when their renewal is due. This fourth strategy that we currently have ongoing, we do have some improvement that we need to make to our notices to make sure they're clear. We have a wonderful group out of the MAC that was formed back in August of 2021. This group meets monthly. It's comprised of 25 members, which includes several different advocates, Office of Eligibility Policy staff, DWS program staff, and from time to time, executive leadership from DHHS and DWS. The objective of this work group is to identify, review, and recommend changes to our eligibility notices that we send out to our Medicaid and CHIP members. We have had action that has been taken from this group. We've revised several different notices, our verification checklist. We're in the process of putting out our revisions from this group on the must spend down notice and several of our notices that we sent out at the beginning of prior to our unwinding period. We also have a separate internal notice work group that meets, that started meeting last month and is working in conjunction with this work group from the MAC. We feel that, you know, improving our notices and making things more clear to our members is crucial, and it's critical to making sure that they understand what's needed, when it's needed, and where they're at in the process. I think, Stephanie, you bring this up a lot, and it's such a simple thing and was so true. It was brought up on that member panel last week as well, that, you know, we would like some sort of status, like where are we at in the process, you know, and what's happening. That's not always clear, you know. And so I think, you know, we've got to really think through, you know, how can we do that, not only on a my case environment with electronic notices, but with our paper, people who receive paper notices. So I just kind of wanted to talk through that those are some current things that we are actively working on and trying to improve. We do believe that each of those strategies will have an impact on our procedural terminations. So now I'm just going to briefly touch on each of the flexibilities that CMS put out last month, like I mentioned, for states to consider to help prevent procedural terminations. Okay, so this first one is around renew Medicaid eligibility based on financial findings from the SNAP program or TANF. Federal authority is required for this through the 1902 E14. This is a temporary flexibility that's allowed just during the unwinding period. Utah does not currently propose to implement this flexibility. However, we are considering adding SNAP and TANF to our state verification plan to utilize income from SNAP and TANF as an income source. As we spoke with CMS about this flexibility, again, this being temporary, we're really trying to think through ways to implement long-term strategies to help not just during unwinding, but for the longer term. And so we feel that you know, by adding this to our verification plan and having it be a long-term strategy where we're able to access their income and update a renewal will help us to reduce those procedural terminations. And yes, Rachel.
Rachel's got a question, and then I have a question, please.
Perfect. So this is going to be a question that applies to, I reviewed this ahead of time, so I kind of know what's already coming up. When you say that Utah does not propose to implement these flexibilities, is that due to the fact that you need legislative approval to do so, or something like that? Just because, you know, if it is a legislative approval thing, we as members can start talking to the legislature about this issue if they really, if that's what needs to be done. I mean, they have the ability to call themselves into special session if some of these folks, if that's the reason why, or if it's just a choice on the part of a department. I'd just like to know.
Yeah, no, that's a great question, Rachel. Let me address that. And then I can see, Brian, you want to add. So let me try to address this first. That's not the reason. We're not required to seek the legislative authority for these. However, with that said, I think, you know, I probably should have started out that, you know, as a state, like I mentioned at the beginning of my unwinding presentation, we are currently in month 5 going into month 6 of unwinding. And a lot of these strategies not only potentially take some system changes, but even procedural and training changes to workers. I think you also heard from Dell, you know, workers are overwhelmed right now, just trying to grasp the current concepts, right, that are in front of them. And so as we've talked this through, between both of our agencies, we're trying to figure out what, you know, which of these strategies are probably going to be the best ones for us to pursue and the easiest in terms of, you know, implementation, and not just easiest, but will actually be affected in the best way, right, and make the best impact. And so I don't want it to come across as we're just dismissing these when we've put on here that we do not propose. It's just that we've had very lengthy discussions through this strategy, and we figured, you know, here's our best way to approach trying to improve the procedural terminations. And I don't know, Brian, if you wanted to add to that.
No, I think you did an excellent job. I would just kind of give a broad philosophy that what we took into account is what's likely to be most effective in reducing procedural determinations and what is most likely to have a long-term implementation. A lot of the 14 flexibilities are time limited. And so that 1A, we are proposing a different way to use the same SNAP and TANF income as an additional verification source that allows us to do more individuals via ex parte. So it's our alternate solution and a permanent solution, which we think is effective and a better option.
Okay, thank you. So back to my question, I was similarly just going to ask, rather than just stating Utah does not propose to implement the flexibility, explain the why, please, and why you don't think it's okay. And I appreciate the dynamic of what's long-term implementable for sustainability reasons and leveraging resources. But if you're truly feeling the pain and desperation of people who are having their cases closed because they don't understand what's happening to them, I think we're going to ask you to explore some of these options that may not be long-term sustainable if you're in a crisis and you're trying to actually solve a problem today. So if you could kind of speak to that on B through the remainder of the document, rather than just giving us a statement of you don't recommend it, we'd like to know the why and why you don't think that's going to be effective in the short term, recognizing there might be some programming issues and training. I think that makes sense. But if there are any of these that could be implemented quickly and aren't going to revolve around additional training and programming that's going to be implemented too far after the crisis, I think a genuine good faith effort at reviewing what can we actually do from these would be helpful to all the members of the MAC.
No, I really like that feedback, Michael, and absolutely 100% agree that it makes sense to explain that why. So knowing the limited time that we have left in this meeting, I can promise that we will go back and add that to this document and have that resent out from Sharon. But I can attempt to go through the remaining ones in the remaining time that we have. Does that sound okay?
Yeah, we've got just under 10 minutes. So I think we're probably not going to solve all the problems, but if you could just kind of give a brief overview on maybe the ones that you've said you don't think are workable or you haven't recommended, some that you think you might be able to go back and they might work in a crisis if there's not programming or a lot of staff training that we could use as some intermediary measures. If you could just highlight some of those, because we have had the document to look at.
Yeah. Okay, I'll do my best. Feel free to direct me somewhere else if I go the wrong direction. Okay. I think I understand your request. Okay, so moving on to this next one with express lane eligibility for children. For this one, we have actually explored this, not just due to unwinding. This has been out for quite some time. This one, at least from our perspective, didn't make a whole lot of sense because of the system programming, as well as the limitation to just for children. And we know, we have variable households, on our Medicaid and CHIP programs. So it just becomes very difficult to implement this one. It's a little bit more complex. Now, again, that doesn't mean that we can't consider it. It's just that for right now, this is one that we do not propose. Okay, so obviously this next strategy we did implement. Again, recognizing, trying to find ways to help us during this unwinding period and where it made sense. So we did implement this next strategy on renewing Medicaid eligibility for individuals with no income and no data returned on an ex parte basis. D, renewing Medicaid eligibility for individuals with income at or below 100% of federal poverty level and no data returned on an ex parte basis. This was updated by CMS. Again, if you click on that link that I provided, it takes you straight to those CMS flexibilities, which gives a lot more information on this one. They updated this one to try to include specifically self-employed households. A lot of states, including us, struggle with we don't have a data source for someone who's self-employed, right? And so this was a strategy that CMS put out there and, for states to consider, using the strategy during unwinding. Again, it's a temporary strategy. In terms of implementation, we felt that this would be difficult to try to train workers on and implement in the time that we have and actually make the right impact that we want to make with this flexibility, if that helps. So this next strategy on the renewing individuals, Medicaid individuals for whom information for the asset verification system is not returned or is not returned within a reasonable time frame. We actually have implemented this strategy. We did seek that and receive approval for that temporary strategy. F, renewing Medicaid eligibility for individuals with only Title II or other stable sources of income, pension income without check required data sources. This is also a temporary strategy. So just, I think the same reasons that I mentioned before, just thinking through, the impact to other programs in the training and, would this be implemented in the right way, and so wanting to keep our focus on just improving upon the strategies we currently have in place and being very careful about introducing any new ones to staff, just worrying about them actually picking up the policy around that and the right way to do that. This next one, renewing Medicaid eligibility for individuals with stable sources of income. Many life insurance policies, when no useful data information or source is available. This one does not require federal authority. However, we do not propose to implement this strategy. We currently have a lot of data sources available to us, so we don't feel that this one was necessary to implement. And would obviously take a change to our, I believe, our current verification plan that we have approval from CMS on.
Okay, Michelle, let me stop you now because we're at 2 minutes and we need to wrap up the meeting. But just looking at like number I, suspend the requirement to apply for all other benefits. In the case where someone has been terminated from Medicaid and they're trying to reapply, and they're just trying to get back on the program, why wouldn't we allow them to just complete a simplified application rather than apply for all other benefits? And there might be a great reason. I think these are some of the considerations. It's kind of discouraging to come back and look at almost every one of these. Utah does not propose to implement this strategy. It seems kind of like a nice talking point, nice platitude, but I will put the question to the departments. If your son or daughter was on this program and at the risk of losing eligibility, would you be taking the same approach you're taking? And we'll continue this discussion next month because I think there's a lot of interest in this. And between now and then, I would like the departments to go back and re-examine your efforts here. I know you're busy. I know you have a lot going on, but this is something that we would like to see done as best as we can. So we are at time and we're going to go ahead and end the meeting, and I will reach out to the rest of the MAC members, talk about what type of vote we would like to take next month and what type of a letter that the MAC would like to consider entertaining submitting to the departments with our concerns and lacking confidence in what's going on. So we'll be done. Thank you.
Thank you, Michael.